I've been doing primary care and general medicine at the Harvard West Roxbury office since 1987, and now part of the Advanced Health Group. We've had a lot of name changes along the way, but we're still really truly a community-based, multi-specialty practice. We cover 17 areas in Metro Boston. We care for some 45,000 patients over the age of 65, and about 5 to 10% of those, 5 to 10,000 patients actually, are frail, have dementia, multiple chronic conditions, and that subgroup consumes 2/3 of our Medicare reimbursement. I've been practicing for 23 years, mostly in the office, teaching, managing healthcare, and I can safely say after all that time, really what gives me the most professional satisfaction is a home visit. I do only a handful of such visits every month, sometimes for end-of-life care, sometimes in long-term care facilities. Most often, my visits are to a patient's 1940s vintage home in Rosendale or West Roxbury, or Dorchester or Hyde Park. And these are homes with icy entranceways, rickety narrow stairs, typically cluttered but very cozy living rooms where finding the old and the new prescription bottles is the first big challenge. In the first few days of medical school, doctors are taught the principles of the biopsychosocial model. But too many of the big spenders in healthcare, which is us, the physicians, really have delegated the psychosocial aspects of healthcare to others. Realizing how the home situation affects illness does require an understanding of the role that the home environment, relationships, and social supports play in our patients' health. Most of you, all of you understand that. It's a challenge to get primary care doctors to buy into that. Home care visits, of course, are rare today for today's compartmentalized physicians. Typically, they may find that they're spending all of their time in the exam room or on the computer, in the specialty suite, or as a hospitalist. So what then really is the doctor's experience with home health care these days? And sad to say, 55 years after Medicare began reimbursement for home health care, the extent of most primary care doctors' interaction with the system is really limited to ordering a VNA visit and then signing forms. Lots of forms, every 6 months. And as you might guess, the odds of a doctor actually reading through the form is inversely related to the number of forms that they get. The work of visiting nurses, physical and occupational therapists, social workers, and home health aides is, of course, very appreciated and valued by patients and their families. And the 3% of the Medicare budget that is devoted to home health does a lot to keep patients out of hospitals and long-term care. Together, hospitals and long-term care account for the bulk of U.S. healthcare dollars. The questions I've been wondering about for some time now are ones that we know Medicare and state and local agencies are asking. Can effective home health care be part of the solution to these unsustainable rates of increase in global health costs? How can the home health care industry contribute to the proposals on the table today? Advanced medical home, accountable care organizations, and programs to address seemingly irrational variation in healthcare costs, global healthcare costs, which vary tremendously from region to region, even from zip code to zip code. I think the answer to the first question is an unqualified yes. Home health care can become more effective in helping payers and patients alike reach their goals, tempering the rise in healthcare costs and keeping clients and patients out of the hospital. How to do this, I would like to come back to the forms that us doctors are signing but not necessarily reading. Medicare administrators surely know that primary care doctors must get more engaged with the home health process. There are new Medicare face-to-face requirements for periodic doctor-patient visits, and we know that this will get some patients in for needed continuity with their primary care doctors, and will probably reduce some cases of unnecessary home care, and perhaps once in a while generate a much-needed home visit from a clinician. But my fear is that the predominant effect of the new mandate will be more forms to sign without meaningful integration of the office and the home-based care. Fragmentation, unfortunately, has been the rule in U.S. healthcare for decades, and breaking down the silos of primary care office, specialty clinic, the home, the hospital, the skilled nursing facility is not easy. I will share briefly some of our experience at Harvard Vanguard showing it is possible to break down fragmentation. Some years back, when I realized how meaningful the house call was, I also learned that having the right home care team in place would be much more effective than occasional visits to the doctor, either in the home or the office. In West Roxbury, we were blessed with the good fortune of finding a small cadre of really very good visiting nurses who really got it. They understood that having a true team of healthcare professionals working together on common goals, one patient at a time, made all the difference. We developed standards for evaluation, and more importantly, we developed expectations for communication among the team members. Our primary care doctors were initially skeptical about the prospect of getting patient care phone calls in real time, and then making their schedules flexible enough to accommodate our patients' sometimes urgent need for office evaluation, to prevent a hospital or an ER visit. Just as importantly, it was important to have flexibility to see the patient as soon as possible after hospitalization, in the doctor's office or in the home, to be sure they were on the right track toward health, that they were doing the right thing with their medications. You all know that anytime a patient ends up in a hospital or a facility, there's a new list of medications. It may or may not correlate with the prior list. Unfortunately, doctors are very good at adding medication. We're very poor at never stopping or removing a medication, especially if it was prescribed by someone else. That's how a patient can end up with 21 medications. It might be necessary, but 14 might do the job, actually with less side effects. In recent years, our home health partnership model has been broadened, and we have developed some close working relationships with hospice and with other elder service organizations. We include representatives from the community agencies in our case review team meetings, and we are piloting methods of individualized care management to get each frail elder followed by one person through any venue of care, just perhaps defeating the forces of fragmentation. Harvard Vanguard has also developed what we call an intensive home-based program, which is staffed by nurse practitioners, physician assistants, working closely with our visiting nurse partners. These clinicians get out to the home within a day or two of hospital discharge. They tackle the confused medications, the home safety issues, and they try to clarify home supports, the patient's goals of care, and the advanced directives. Does all of this provide that elusive advanced medical home for seniors that we've been talking about? Not yet. We do have islands of success. Our West Roxbury practice has a Medicare hospitalization and readmission rate that is 30% lower than other practices in the area of similar morbidity. And our intensive home-based program has reduced readmissions by 25% for very high-risk patients. If I had more time, I could share with you many of the stories of success that give rise to statistics like this. So what else do we need for our practice, or any practice, to be an effective medical home? The answer to this, I believe, lies in recognizing that our older patients, they need more than just a home. Elliot Fisher at Dartmouth has phrased it correctly. What he says is that what's required is coordinated, high-quality, cost-effective care in a medical neighborhood. In this neighborhood, people and hospitals, practices, and community-based agencies, they know each other, they talk regularly and informally, but they also have management structure and communication channels that further the relationships. Not just the goals are shared, but the strategies are developed together. And the essential piece of information, which is what's going on with that patient, that client, that neighbor, that information is shared by all, using HIPAA as a tool for respecting privacy, but not allowing it just to function as a bureaucratic barrier. Now, just add some shared monetary rewards for high performance of this medical neighborhood. That would be quality measures, team communication standards, fiscal performance. Do that, and we will have an accountable care organization. Simple, right? It's actually a vision we see as reachable in our practice at Harvard Vanguard at Atrius. In this conception of the medical neighborhood, effective integrated home health care really takes on an importance in achieving our goals that goes beyond its fairly modest contribution